thoracic lateral.
Two more souls while I'm sitting here.
So we already went over this. We're going to be seeing the shoulder and the proximal humerus projected through the thorax using orthostatic breathing to be able to blur out the ribs. And we're looking at our scapula, clavicle, and humerus. So we already went over that. Next, we're going to be looking at the inferior superior axial projection. Inferior superior, going from the inferior portion through the superior portion. Axial meaning angle. We're going to be angling our tube for this projection. Also goes by Lawrence method. For this, our patient is going to be primarily supine. Head and shoulder are going to be elevated. We'll typically use maybe a wedge or some type of radial support for that. And the sheets maybe if we have to, not optimal, but could be used. And our head is the head is going to be turned away from the central ray. That's not superimposed on the anatomy. Yes.
In lab, when we turned the head away, it allowed us to get like a better position for the IR as well. Is that also another reason? Or?
Yeah, it's going to allow you to get that IR deeper where it needs to be. Part positioning on this, we're going to abduct the arm, so at a right angle, and if possible, place it in external rotation. IR is going to be crosswise on the table as you see there, and we're going to want to put it in the support that music stand, or if we don't have one available, maybe have it lean against something like a sandbag or something else.
You don't have the patient hold it?
If they're able to, yeah, they can also hold it. And of course, centered at that shoulder joint there, and we shooting right through the armpit there. Do you guys do this one in lab?
Mm-hmm.
Yeah.
To make sure to shave your armpits for it? You kind of did? Yeah, did you guys make sure to shave your armpits for it? We did, when we did it.
Not to go short.
You guys shaved it?
Smelly boy.
Yes.
You said it's axial because of the angle, not because it's axial? Or is that
Yes,
some-
it's axial because of the angle. Anytime we have axial, it's because we're angling the tube.
What is this called? Is this called axial?
Axilla.
Axilla.
Axilla. So similar, kind of sounds similar, but it doesn't really relate. Our central ray is going to be a horizontal ray. Medial angulation of 15 to 30 degrees. And it does enter the axilla, or the armpit there. And the angle does depend on the abduction of the humerus. The more we abduct, the greater angle we're going to need. As far as the collimation, it's going to be about 12 inches in width and about an inch above the shoulder there. Important note to remember that medial angulation was about 15 to 30 degrees.
This is a tube angle you can keep it 50 degrees.
Tube angle 15 to 30 degrees.
What was the question?
This is the tube angling at 15 to 30 degrees?
Correct.
Yes. Tube is going to be angled 15 to 30 degrees.
So it's hitting the IR like that. How is it horizontal?
Because it's kind of compared to like a cross table projection. They've got a horizontal beam. Yeah. Sort of how you do your DQs.
Towards the patient.
That's a great X-ray for babies. You can check them for dislocations because trying to get a Y shot on an infant or baby is a nightmare. That method right there is your best friend. Used to do those all the time.
So this is how that image would look once we do those. Notice that the lesser tubercle is going to be on the superior portion of this image. Greater tubercle would be on the inferior part. On this image, we're going to be looking at the proximal humerus, scapulohumeral joint, lateral portion of the coracoid process, you see there, and the articulation of the AC joint.
And just remember, just so it doesn't throw you off, guys, on that one particular image that being that Lawrence method, just always make note that lesser tubercles at the top of the film. So that's gonna look a little different than your internal rotation, because the way the arm's positioned. But in that one particular image, that lesser tubercle is what we see in profile. It's at the top of the film. You always wanna label that as the greater. That's actually the lesser.
Yes.
Why does the lower image look so like different?
Could be a technique issue.
Okay.
You ask why it's so gray?
Yeah.
It's probably a film X-ray, if I was to guess.
Yeah.
Just a much lower quality.
So again, key points, that lesser tubercle is going to be on the superior part of this image. And superimposed on the humeral head is going to be the acromion. You see that? So it's a bit of a weird image. The anatomy kind of gets thrown off from where we normally see it. Yes.
So, what kind of situations would happen that would need to use like this projection? Because like this isn't trauma, right?
Right, this isn't trauma.
Okay. It's not, or it is?
Wait, it
It's
is?
not.
I mean, it doesn't have to be, but it's most commonly used in trauma because the ideal position is considered to be the Y shot for dislocation, but obviously if they're on a backboard, obtaining that Y shot's gonna be extremely difficult. So this would be a better option in that case to check that dislocated humerus.
So they're gonna be able to like move their arm like
Not
that?
always, but we're gonna get that range. So if the arm is like more
Oh,
neutral, you can just do a
yeah.
15-degree angle versus
Oh,
30 degree.
okay.
Yeah.
Gotcha.
Do you have a question, Jay? No. Our evaluation criteria for this image here, scapulohumeral joint is going to have a slight overlap there. Coracoid process is going to be pointing anteriorly. And we're going to have the lesser tubercle in profile, which is what we're going to see here up top. AC joint, acromion, and the acromion end of the clavicle are going to be projected through the humeral head. So get familiar with this image, lesser tubercle. Know that the acromion is going to be right there on that humeral head. And that the lesser tubercle is in the profile. This is one of those images that always trip me up.
Do we have one we can label ourselves, like in the slides, or?
I believe, I'm not sure if it's on the slides, but I believe you guys did get one on the worksheets that we did go over. Next image is going to be, next position is going to be the PA oblique scapular Y. And it's named this because we're going to have a nice Y shape. The acromion and the coracoid are both going to form those branches of a Y, and the superimposed body of the scapula is going to be the stem of that. And we primarily do this position to be able to visualize shoulder loop dislocations.
Add to your notes, this is sometimes also called a trauma shoulder. It's gonna be a trauma view, trauma shoulder. Well, you do include it in the protocol here itself, which is for every shoulder series.
And this is how it's going to look positioning wise. Upright position or recumbent position, and we're going to do an RAO or an LAO for these positions. Affected shoulder is going to be closer to the IR, And notice the degree of obliquity is 45 to 60. So it's a bit of a larger oblique than usual. When we position the patient, we're going to palpate the scapula and place the flat surface perpendicular to the IR. And as far as arm positioning, there's no particular arm positioning. It's not very critical in these cases for this position. Just kind of have them by the side, neutral is fine.
That's why it's usually for trauma views. 'Cause if their arm's dislocated, you're not going to want to look like that on it anyway.
Correct.
I do want to make a comment on the position here, guys, because you're going to see a lot of techs doing LPOs and RPOs. For your curriculum, for Merrill's, the gold standard for this position is REO and LEO only. That's the one that you ideally want to attempt.
Hmm?
We're going to show you the opposite? Yes. Correct. The ratio.
Central ray perpendicular to the scapulohumeral joint. Collimation 10 by 12 lengthwise. And why are we doing lengthwise on this? The scapula is longer, so we want to go lengthwise to be able to see that entire scapula.
You don't even see in that picture there, see how it's making that Y shape? I think we talked about this on Wednesday. Does anybody know why there's such a range in obliquity? Like, why does it say 45 to 60? Why not just 45?
Because people have different scapula.
Scapula is very correct in size, shape, and position of the body. So gives it a little range to manipulate because I'm sure some of y'all have seen in clinic already, some people doing these Y shots. Sometimes you have to take more than one X-ray. It's not perfect first time. Anyone seen that? Yeah, it's kind of a I mean, I hate to say shooting blind. You're kind of shooting blind on this because you don't know what their scapular anatomy is going to look like until you shoot an X-ray. You need to make those little adjustments, especially if it's more oblique.
Emily,
Make sure it's nice and
So,
nice and true lateral.
Emily, do you have a question?
Is this a position that depends on like their habitus?
Not necessarily.
Like if they're more sthenic or more asthenic?
So good question. Not necessarily body habitus. It's just every person has a different shaped scapula. There's little variances in the shape and the way it sits in the body. So you have to make those adjustments accordingly once you take the X-ray. Hopefully you get it the first time. If you don't, you gotta adjust slightly to get that nice true lateral.
Yeah, so usually from experience when I've taken these, we take the image and then kind of tell the patient don't move, just stay right there. That way, if we need to reposition them, we can just adjust based on what we see from the image. Here's what one of those would look like. You see the Y shape formed here, acromion and coracoid forming those branches, and the superimposed body of the scapula forming that stem of the Y. So this is a trauma. This would be a trauma position, so we wouldn't typically move the arm. So you'll see that humerus is going to be there superimposed with the body of the scapula. Humeral head and the glenoid cavity are superimposed as well. And superimposed body of the scapula laterally in profile. With the borders, the medial and lateral borders superimposed upon each other.
And do make note on this image, because we're going to be talking about a lateral scapula here in a second. There is a clear difference between a scapular Y, the PA oblique scapular Y, versus a lateral scapula. Because this one is evaluating humerus dislocation. We do want that humerus superimposed on the scapula like you see right there. But if you see the scapula by itself, the humerus crossed over, that's an indication that we're doing the lateral scapula, which is a different exam. They look very similar, but look for the position of the humerus. That's gonna be your key indicator there.
Evaluation criteria here, superimposed on the Y. Humeral head will be superimposed on the Y on a normal shoulder. Of course, if it's dislocated, it will be shift either anterior or posteriorly on this image. If it's below the coracoid process, that's the indication that it's anterior dislocated. If it's below the acromion, it's an indication that it would be posterior located.
Can y'all see the dislocations in those two images? See, the first one on the left is a normal shoulder, but the other two, we got dislocations going on. Look at the humerus.
The other one, the second one.
What did you
Is
say
it
about the,
anterior?
oh, never mind. That's it.
Both of those are examples for anterior dislocations, by the way, because they're both
Below
going
the
towards the
coracoid.
coracoid. If that humerus is going more towards the acromion, like more lateral, it's gonna be a posterior dislocation. So I think what y'all had asked the other day, like, does the humerus dislocate towards the rib
Yeah.
cage?
So-
Well, yes, it does. If you look at that middle image especially.
They're both anterior because they're both below the coracoid process.
So as you see, they're coming in and below the coracoid, so that's indication of anterior dislocation.
Yeah.
So a couple of review questions here. What is the required patient position to demonstrate the left shoulder and PA oblique, also known as the scapular Y?
45 to 60 aria.
45 to 60 aria. Anybody else want to chime in? Have any LA you said?
Both?
Oh, I'm sorry.
What you're
It's the
looking
left
at is
shoulder.
looking
what's the
for-
question say?
Left shoulder.
Left
Oh,
shoulder.
Left shoulder. LAO.
LA.
So it's B.
It would be B, LAO. The side of interest is the side that we're going to have closer to the IR. So if we're looking at the left shoulder, we ought to be doing the LAO. Next question, how is the affected arm positioned to the, for the inferior superior axial projection, the Lawrence method? What do you guys think?
A is
Should
an
be an
opposite.
A, here an A, abducted to a right angle in an external rotation. Okay. Anybody else have any other thoughts? Or are we all agreed on A?
Okay.
A. It is A. Abducted and impossible in an external rotation. That is that armpit shot. Lawrence method.
What is the point of having it, if it's possible to do this? Is
Why do
there-
we do that? To
Yeah.
put that, because with that certain position, that's gonna put that lesser cervical profile for us
Okay,
in that position.
yeah.
And Lesser's on the top for that
For
position.
that purpose.
So we're gonna go over some projections for the AC joints now, which I believe should be two. Oh, there's just one.
For these joints.
Oh, okay. Oh, well, AP projection, weighted and unweighted.
Correct.
There you go.
It's 72.
So yes, 72 inches. This is gonna be called the Pearson method for that AP projection. And we're gonna be doing these upright. Arms hanging by the side, no support, because we're wanting you to see those AC joints opened up. And we're gonna do two of these, one with no weights in the patient's arms, and then one with weights. AP, and we're going to be utilizing what's known as slit collimation, very thin horizontal collimation for these.
When-
Yes.
You said when the doctor orders it, we do two view. Wait, I mean one with weights and without, or is it like the doctor says with weights, or
If they order these, it'll typically be with and without weights.
so two pictures?
Yes.
And that's a great point to bring up, Johns. Do you guys know which one you always do first?
Without.
With
I heard a without and a with. Which one is it?
I would say with.
Without first.
without, because that's what you
This is
did
a
in
very
lab.
important question. You always do without first. Does anybody know why?
Comparison?
Why would I want to do without weights first?
To
Just
see
to
their
see
resting.
Yeah, initial
To see
position.
if, maybe if there's a fracture.
If there's a severe fracture or dislocation of those joints, usually you'll let the doctor know and they will not proceed with the weighted view.
Yeah.
Unless you further injure the patient.
You need to let
So
the
if
doctor
you see
know.
something suspicious, you always want to inform the radiologist before you proceed with the weighted view. And what's the point of adding the weights?
To emphasize.
To bring the
It does
complications.
bring stuff down, but what does it do specifically?
It opens up the joint.
It opens up the joints.
Opens up the joints. And where are you guys using those weights in the lab?
Sandbags.
Sandbags, correct. Usually that's gonna be the weights that you use universally everywhere. It's not gonna be like some actual weights like you see in that picture there, it's probably not gonna happen, but,
And it matters how much weight,
I mean, you do that 5 pound,
at least.
5 to 10 pounds is sufficient.
Yeah, we're not making them look like 50 pounds.
Yeah, you wanna
How many
relax, you
groceries
wanna
can
be
you
like,
take
so,
in?
when you're doing those weights, you don't wanna be like trying to hold them up, you just wanna relax your arms and let them kind of pull your arms down.
Oh, he's like, put the, handle like in your fingers and kind of just.
Oh yeah, you can do that, or you can have them just kind of hang them on the wrist and just grab. There's multiple ways you can do it. The main thing is just not to be holding the weights up. You want to relax with the weights, let them pull your arms down.
Yeah, like you see on this image, this guy here, they're strapped to his wrist,
Just strapped, so it's just chilling.
just hanging down. Just as long as they're relaxed and not like trying to actively lift them.
Get a workout for free. I just ain't joking.
So,
I
central
did.
ray on this, where we're going to be centering, we're going to be perpendicular to the midline of the body at the level of the AC joints. And this is one of those special projections here where we're going to be utilizing a 72-inch SID. This is the only one of these positions that we're going to be utilizing that. And why do we do that? Does anybody have an idea? 72 instead of 40? Want to see both. But is there any other particular reason why we would do that?
Reduces distortion of the joint space.
What was that?
Reduces the distortion of the joint space.
Restricts the distortion of the joint space. Yeah, what type of distortion would we get?
Magnification, OID.
Magnification, OID, yes. So, as you guys know, because there's OID, the joints are going to be anterior to the body here. So there's going to be OID when we place them in an AP position. So we'll want to utilize that 72-inch SID to minimize that OID and any magnification that we get from that. And then collimation again, we're going to be utilizing that slit collimation. This is probably a bit too open for what we want to see here. We're really just going to want very thin horizontal line just to get what we need. And here's how those images would look. We have our bilateral here, visualizing the AC joints. And if there's any dislocation and separation of those joints, we'll be able to visualize those there, which is why we do without weights first, followed by weights if we don't see anything that's contraindicating.
You don't see some of those singular images like that, guys. I've never seen them not do bilateral. I mean, that is an option that exists, but From what I understand, they're always gonna order bilateral to look at comparison views anyway. They wanna see both with the barrel. So focus on the bilateral,
The word bilateral just means two, right?
right, both sides at the same time.
Alright, so that was it for AC joints. It's just one. Next, we're going to go over the clavicle projections. What was it, the next question?
Is that bilateral or the AC?
Yeah, it's just bilateral AP projection of the AC joints. One without weights, one without. Or one with weights, one without, yeah. So here's our projections for the clavicle. AP, PA, AP axial, PA axial. Note that the PA projections are preferred because they reduce OID and improve the quality of the image. And AP projections are going to be used on recumbent patients.
So I wanna make a note here too, guys, because you're probably never gonna see anybody do PA.
Yep.
I've never done a PA clavicle, because it's very hard to get that correct. Just make note that as far as optimization goes, PA is preferred because it puts that part closer to the IR. But you're almost always gonna see all of us, even in lab, use APs.
Yeah.
It's pretty standard.
Never seen a PA clavicle in clinic. It's usually always AP.
You're shooting blinds with PAs.
So, should it be AP projected preferred?
No, well, PA projections are preferred if you to optimize the quality of the image,
Listen.
but primarily we usually only do AP for the most part.
And you still keep it at 72, right?
No.
No, these are 40. The clavicle.
Oh, I'm sorry, I was thinking
ACs
AC
are
joint.
only
Yeah.
72-inch projection. In fact, that's like only 72-inch projection this whole semester,
Well,
if I'm thinking correctly.
Alright, so all those positions that we just went over, all those projections, they're all going to use the same type of collimation, which is that slit collimation. 8 by 12 inch IR is what we're going to be using. And we're going to want about 1.5 inches line above the shoulder and 1 inch lateral to the shoulder. And of course, we're going to want to make sure to include the entire clavicle that we're looking at.
Fun fact here, guys, if you ever work pediatrics, almost every, well, I wouldn't say almost every, but a large majority of births that occur naturally without C-section, they'll often order a clavicle series. Does anybody know why?
Like the baby?
You're saying without a C-section, right?
I'm saying natural birth, non-C-section.
Is it because they get stuck in the canal?
There, yeah.
With the pressure they go to.
They do, yes, they do get stuck, and with natural births, a lot of times a baby will suffer a clavicular fracture, I can't talk. And they'll often order those clavicle series on natural births just to double check to make sure the baby's okay.
I saw three of those.
That
I
happened.
saw three
You
of them.
saw three of those.
Yeah, I went up in portables so that they can do some
Clavicles.
clavicles on
Mhm.
some.
So if you need a clavicle comp, hang out in the pediatrics area with Portal Tech, because they come in quite often.
That's, yep.
Yeah.
They told me that about Andrew, that he was too big and that he could have had clavicle damage. That's why I couldn't have him natural.
Yep, it's a very common
Yeah,
occurrence.
mine was natural, but they had to push on the shoulder, and that's how they came. It was stuck.
Did you have a fracture or anything?
No, they checked the,
What is the term that you use for collimation? Slit cut or slit cut?
Slit collimation, SLIT. So just a
Slim,
slit.
sort of slim. Slit collimation for all.
For all these clavicle projections that we're going to do. Do you have a question?
Yeah.
Okay. So first one we're looking at, AP clavicle, upright or supine. Clavicle is going to be centered to the vertical grid. Arms are going to be at the side, shoulders in the same horizontal plane, so we don't want our patient leaning to one side or the other. We want to make sure they're upright and straight. Central ray is going to be perpendicular to the mid shaft of the clavicle that we're looking at. And there is a respiration for these positions. For this one, it's going to be exposure made at the end of exhalation.
Is that to bring it more perpendicular to the CR?
Our evaluation criteria, of course, we're going to want to see the entire clavicle in this image. The lateral half of the clavicle is going to be above the scapula, with the medial half being superimposed on the thorax. Just to make sure we're still aware of our anatomy, what would this end of the clavicle be? Sternal end of the clavicle. This piece of anatomy out here, this landmark? The chromium. If we're looking for the landmark here, what would that be? Glenoid cavity, and what would the joint be? Scapulohumeral joint or humeral scapular. PA clavicle, patient is going to be standing or seated upright, facing the IR. And we're going to center the clavicle to the midline of the bucket. Same part positioning, arms are going to be relaxed, shoulders placed in the same plane, not having the patient lean one side or the other. Central ray is going to be perpendicular, exit the mid shaft of the clavicle. And same expiration, we're going to be making this exposure at the end of expiration. As they breathe in, they're going to tend to kind of come up, so it's going to put things out of line. So we want to make sure they're relaxed on that expiration. AP, axial clavicle. When we hear axial, what is that an indication of? Angle of the tube. For this, we're going to be using an upright position, lordotic if possible. If it's not possible, we're having the patient be supine with the shoulders in the same plane. So just upright, same plane, not having them lean over to one side or the other.
I want to explain this as well, guys, because this is another thing you're never going to see. You're basically saying you can do the lordotic position to throw that clavicle up above the apices, kind of like y'all remember from chest x-rays, the lordotic, but that's something that you're once never going to see in clinic. We're almost always, and I always have when I use these as well, you're just going to have them stand straight up and use that 15-degree angle, ideally. That's what you almost always do. But you do have that lordotic option if you so choose.
And center of the clavicle is going to be centered to the vertical line of the IR. Arms placed to the side of the body. Central ray for this. When we have our patient standing, we're going to have a 5 to 30 degree cephalic angle. If they're supine, 15 to 30 degrees cephalic.
15 is almost always the best angle, by the way. Just from personal experience.
Now the amount of angle does vary with the thickness of the patient, so body habitus does play a factor into this angle. The thinner the patient is, the more angle we're going to need to be able to throw those clavicles up to where we want to see them.
Would we do it supine as well?
Yeah, so we can do these supine, and if they are supine, we are going to have a greater angle for these, usually 15 to 30.
You said thinner the patient, what's the diameter?
Yes, thinner the patient, thinner the patient, the more angle we're going to need. And on these, the exposure is actually going to be made on inspiration. Inspiration to be able to puff that chest up and throw those clavicles higher. Everybody good? Did they need me to go back? Good. PA axial clavicle. Patient position, the patient's going to be standing facing the IR. Or if they're recumbent, they're going to be in a prone position. And the central ray, again, 15 to 30 degrees. This time it's going to be caudal. So remember that AP is going to be cephalic, and the PA axial is going to be caudal.
And once again, AP is what we're almost always gonna do, guys. It's
Yeah.
just, it's considered the optimal way, but you'll see most of us always doing the AP axials or the PA axials.
And that compensates for the just natural shape of the clavicle and like where it's at during that cephalic caudal.
So your axials, they distinctly are gonna raise that clavicle above the apices and the shoulder just to get a better visualization of it. But it make them more horizontal as well. It comes with the shape like you mentioned.
Yes.
This has nothing to do with this image. It does, but not the position of the
Sure.
patient. Going to the coracoid process on
The coracoid process? That'd be right here. Alright, evaluation criteria for the AP and PA axial clavicle. The lateral 2/3 of the clavicle are going to be projected above the ribs. So we're going to throw those clavicles up with that angle. Scapula and medial end are going to be superimposed on the thorax. Of course, we know our clavicle is going to be in a horizontal orientation. And we're going to want to visualize the entire clavicle. That's including the AC and SC joints. So based on that, do you think this image here would be optimal?
Yes.
Yeah, the marker wasn't visual.
The
Yeah.
marker looked at
Ignoring the marker, patient positioning wise, this would be optimal. We do have both our AC and SC joints there, and have the entire clavicle there, and it is elevated above the ribs there.
What was the angle again?
So the angle for these, it's going to be about I'd say 5 to 30 degree cephalic angle for the AP.
AP it's 5 to 30, PA it's 15 to 30 only.
15 to 30.
But to be safe, always go with the 15. That's your best angle overall. Most average body shapes. That's a good stopping point.
Yeah. So we'll go ahead and stop here for today. Thank you guys.